So now we have Dr. Jyoti MATALIA, and her paper is winner of AIOS Athawale Award. She's going to talk on outcomes of optic nerve sheath fenestration in atrophic papilledema.
Yeah, so good morning all, and I'd like to thank AIOS for this opportunity and for the award as well. So I'm going to be talking on the outcomes of optic nerve sheath fenestration. We are aware that raised ICP results in papilledema, and that causes visual loss. So the goal of treatment is definitely to reduce the ICP depending on the cause. So in which cases an optic nerve sheath fenestration is kept to relieve the compression on the nerve and preserve or improve the function. But the issue is, in cases where we have an atrophic nerve, where the nerve is flat and already failing, is there a role? With this in mind, we had our study, and that was a research question, where we decided to report our experiences with ONSF for visual loss in patients with atrophic papilledema. It was a retrospective interventional study where we did ONSF over the last 10 years and compared it, and found that we had 48 eyes of 27 patients with atrophic papilledema. All of them underwent the routine protocol that we normally do, where vision, color vision, contrast, B-scan, visual fields, and stereoscopic disc photography is done. So all patients diagnosed with raised ICP with or without maximal treatment, but having disc pallor like this with or without edema, but a B-scan showing subarachnoid fluid, as you can see here as a crescent, hypoechoic crescent, was included in the study. They all underwent optic nerve sheath fenestration by the medial transconjunctival route under general anesthesia. In terms of outcome measures, it was the visual acuity and the visual fields which were checked, followed by the disc edema, whether it was persistent, resolving, or completely resolved. So finally, we had about 48 eyes of 27 patients that underwent ONSF, and the mean age was 33 years. We had equal number of males and females, and flat disc was in 21 eyes. That is about 44%, where we may have presumed that the disc is already flat. So do we really need to do something or not? We had about 13 cases, that is 48% of IIH, followed by CVT as the other cause. Now, optic nerve sheath diameter was seen as an average of 5.33 pre-operatively, which improved to 3.39 post-op. And visual fields are possible only in 17 eyes with an average MD of minus 21.34. A minimum follow-up was about 6 weeks to about 2 years. So we divided them into the unilateral and bilateral cases. We had 6 unilaterals, so 6 eyes underwent surgery, 21 bilaterals, so 42 eyes. Of this, those with good vision, we operated in the worst eye, that is out of the 4 patients. Among those with poor vision, one with the low vision, we had operated in the left eye because that had some amount of vision in that child. And one patient with no PL, we operated only one eye. Of the 21 bilateral cases, good vision was in 6 eyes of 3 patients and 6 eyes of 6 patients between 6/6 and 6/60. In poor vision cases, 16 eyes of 11 patients had counting fingers to 5 meters. And the others had about 14 eyes which had either hand movements, PL, and no PL. So what we realized is those which had good vision continued to improve and or either remain stable. And in all of them, the visual fields were possible, but they also improved. In the one with low vision, yes, it remained stable. Similar in the other cases, which had ambulatory vision. But those which had either PL, hand movements, or no PL did not show any change. Let me discuss one case which had good vision in one eye and poor in the other eye. This was a 49-year-old patient from Iran. And if you see, he had vision of 6/18 parts and 6 by finger counting 1 meters. You can see the discs are completely gone, and OCT also showed flattening, which gives a wrong impression that everything is fine. But when you look at the B-scan, you'll see significant amount of fluid which is present. And if you look at the surgery that we did here, you'll see that the sheath is completely enlarged. And if you go in and do a sheath compression, see the amount of fluid that comes out, indicating that there was still fluid. And it's important to do this fenestration so as to remove the pressure on the nerve and allow the vision to remain constant. And if you can see that this was the preoperative B-scan, which after 4 days completely vanished, indicating that the nerve can be now salvaged. Coming to our results, we realized that out of the 48 patients, 48 eyes, 24 eyes had a vision more than 6/6, and 6/60 did all well. 10 eyes with vision less than 6/60 had ambulatory vision, but those with poor vision did not show any change, which means out of the 48 eyes, 34 eyes had at least ambulatory vision, which means about 100% success in that, of which vision improved in 11 eyes and stabilized in 23 eyes. We found complete resolution of papilledema on B-scan in all patients, which starts within 1 week and completes by 4 weeks. Visual fields remain stabilized, and there was no vision-related complication. So what we already know that optic nerve sheath fenestration is indeed a good procedure, but there are no studies of atrophic papilledema. And what our study shows is that it's the first case of ONSF and atrophic papilledema. It can help salvage vision even in flat eye, flat pale discs. Ambulatory vision is possible in all cases if there's a pre-existing vision of counting fingers. There's no role of ONSF if vision is PL or no PL. And B-scan is an important tool to decide whether to intervene or not. Thank you very much.
Dr. Jyoti, so what is the carry-home message? What cases of flat papilledema with pale disc, without PL, you said it's not...
It's of no use.
Yeah.
Anything with counting fingers, better than that, and you need to have a B-scan showing that there is still fluid behind it.
There is some fluid
Yes.
in the
subarachnoid space, because that is the actual communication with your the brain SAF and the subarachnoid fluid and the ventricles. So if you know that there's a pressure high, your SAF will be evident behind your optic nerve, in which case you need to remove it if you have anything better than counting fingers.
Thank you.
Yeah, thank you.